I think that we as nurses need to advocate when the patient is uncomfortable. And it's not your classic pain in my hip kind of thing. This is a more subtle, I can't breathe, I have a sense of impending doom, I'm panicked, I want somebody beside me. So it may sometimes appear to be a psychosocial coping issue when it really is a physiologic one.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. Today, we're talking with ONS member Brenda Shelton, a clinical nurse specialist at Johns Hopkins Hospital in Baltimore, Maryland, about superior vena cava syndrome in patients with cancer. This episode is part of a series about oncologic emergencies. The previous episodes are linked in the episode notes. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining us today, Brenda.
Thank you so much. I'm excited to talk to you.
So to start us off, when do we see superior vena cava syndrome occur in our patients with cancer?
Well, ironically, superior vena cava syndrome was first recognized with TB patients, and now it's almost exclusively going to occur in patients with cancer because it's physiologically the outcome of too much mass in between the sternum and the spine. If you were to imagine right there in the center of your chest where your sternum and your spine are on top of each other, in between, you've got all your great vessels and you've got about 20 lymph nodes. And so in our cancers that are centrally located in the chest, there's just not enough room. And as a consequence, the very soft-walled vessel, the superior vena cava, gets collapsed. And then you get some clinical effects that we'll talk about later. But it's almost exclusively going to occur in patients with cancer these days, and typically those with chest tumors specifically. Anyone who has a primary tumor in the chest or a metastatic one.
So based off of that, it doesn't have to be specifically related to malignancy, but most commonly it would be.
Yeah, and actually the tumors that we see this most often with are those that we know involve the lung. Obviously, lung cancer, centrally located lymphomas, I've seen quite a bit of this with, but we've seen it with metastatic disease like testicular cancer, sarcoma, breast cancer, even head and neck cancer if we've got some lung metastases. So most lung metastases are going to be more peripheral. That's why we see it more commonly in a primary tumor than involving the lung, like the sarcomas, the lymphomas, and the lung cancers. But you could see it with almost any lung metastatic tumors.
Are there any special populations that might be at higher risk than others for superior vena cava syndrome? You mentioned lung cancer and the non-Hodgkin's lymphoma patients.
I would say that there is a greater risk in a small framed person because there's even less room in that location to house it. And I think if you have severe adenopathy, I would even take that a step further and say those that have perhaps HIV lymphoma that have more adenopathy. And the other thing I guess that I would kind of highlight is the faster growing the tumor would be, the more likely that this syndrome would occur because your body would not have the time to adjust. And so you would have a more rapid onset with a more dramatic set of symptoms.
So for our new nurses that are taking care of those patient populations, they really need to start thinking about that might be a possibility that could happen with someone that they're caring for. So can you tell us what some of the early warning signs of superior vena cava syndrome would be?
Well, ironically, throughout my nursing career, I've not always picked up on this. And I'm embarrassed to say that even as an experienced nurse, I sometimes don't have it on my radar, and then it turns out to be the problem. So what happens is in malignancy, it's usually relatively slow growing. And so the symptoms onset slowly. And if you think about it, your superior vena cava empties the fluid from the upper part of your body. And as it is slowly getting compressed, you're going to see some upper body edema. Now, that tends to be more often on the right because that's where the vena cava comes into the heart. So you might see some very subtle right arm heaviness, edema. You might see a prominent right antecubital or prominent veins on the hand of the right arm or a prominent right jugular vein. But these are all things that can be subtle, and the patient may present with aching of the arm, numbness and tingling of that arm, just really things that don't necessarily raise your awareness because it's not the classic signs and symptoms you see in your textbooks.
That's really good to know that they are, like you said, not classic signs, because for oncology nurses, there are so many things that we're thinking about. You're thinking about all of the treatment related side effects that can happen and things with the administration of whatever that treatment is. So to add on another thing that you have to listen to or look for, that's important to know. And it could be very subtle, like you mentioned. Can you talk about what the late symptoms would be in comparison to those early warning signs?
So quite honestly, when we think of superior vena cava syndrome, we associate it with upper body edema, particularly worse in the morning when somebody rises after having laid flat for all night. Something that we call Stokes syndrome, which is that sense that you can't button your shirt, which most of us don't button our shirts up our neck. But I think that that is what that implies, is that you've got this edema in the upper part of the body. This can dramatically change someone's facial features. And so if you know this individual and you start to see that level of edema, periorbital edema, and they're not on steroids, then that should be a jump out at you kind of set of symptoms. But honestly, the thing that patients complain of most is dyspnea. It is not necessarily entirely due to respiratory problems. In this case, it's due to compression of the vena cava and an alteration of the blood return to the heart that leads to a altered cardiac output. But also just that compression affects the receptors in the lungs that cause you to be dyspneic. Another thing that we do classically associate with superior vena cava syndrome is a very high blood pressure in the right arm as compared to the left arm. We may notice very significant right arm edema, absence of pulses from that edema, not absence, really diminished pulses from that edema, and sort of that high blood pressure that doesn't quite match up with the left side.
Good to know. That's a really good point. And sometimes when we're going in to do our vitals or we have a medical tech that is doing vitals, they may not think to check between the two arms to see if there's a difference in blood pressure. And that's a really great way to be able to see that difference. With the complications that you have just mentioned, are there life-threatening complications that can develop if this is not detected early?
The three biggest things I think about are airway incompetence, cardiovascular collapse, and clotting. As you compress the vena cava, you are going to diminish the blood return into the heart. And this is going to compromise your ability to oxygenate that blood and put it back out the other side. So it's not uncommon to see diminished cardiac output with diminished blood pressure, diminished perfusion, and that takes all kinds of forms. You could see it as low blood pressure, which we would consider life-threatening, but you could see it as low urine output as well. The airway incompetence is quite predominant, and it's not always visible on our imaging, but we have to take our cue from the actual blood gas results and the level of work of breathing. And it's a combination of cardiac and airway, but you certainly can have this compression that's affecting the actual airway. And then lastly, clotting occurs because you've now compressed this vena cava. You've now got sluggish blood flow in an already slower blood flow vessel. And so you could have a full occlusion of the vena cava, which would, of course, be quite dramatic and symptomatic and lead to increased intracranial pressure because the blood can't come back out of the upper part of the body. So I think in a nutshell, I would just sort of summarize airway, cardiac, and clotting that leads to increased intracranial pressure.
So, Brenda, now that we have a nurse that has identified that this patient might be experiencing superior vena cava syndrome, what is done to confirm that diagnosis? And then what treatment is done for these patients?
We're almost always going to see a CT with contrast. But honestly, the shortage of contrast right now has made this difficult. So you have to understand that it's essential that this patient get that CT with contrast because you want to know if there is occlusion of the vessel with clots inside of it, because it will certainly change the strategy. So if I have clots within the vessel, my first and foremost treatment is going to be some anticoagulation. But then I have to treat the tumor, and we're going to treat the tumor most effectively however that tumor responds to therapy. And we will select whether we're treating with chemotherapy, radiotherapy, or targeted therapies according to the tumor responsiveness. Now, that means that if we have a rapidly proliferating tumor like a lymphoma, giving chemotherapy, we might see rather immediate results. But in the solid tumor malignancies, where we might do a combined modality of chemoradiotherapy, we could not see results for weeks. And so there's definitely a challenge for the nurse to understand exactly how quickly we expect to see the tumor itself shrink, because the symptoms will resolve as the tumor shrinks.
Okay, that's good to know too. Now that that kind of plan has been put in place, are there nursing interventions that nurse can do to help the patient in palliating those symptoms while awaiting the treatment to take effect?
Sure. The easiest, honestly, is don't lay them flat. I mean, I would have them plan to be sleeping with their head elevated with whatever level of comfort that can be for them. 90-degree angle is probably too much, but I think just keep in mind that lying flat is going to increase that pooling of blood in the upper body. So having their head elevated. And while oxygen may not be an immediate answer, it's a good thing to try to compensate for that poor perfusion and perhaps that poor oxygenation. So we usually give oxygen therapy. For the dyspnea, I mean, if you take a look at the literature in dyspnea, we certainly know that there's some non-pharmacologic relaxation directed fan therapy. But the mainstay of dyspnea management is opiates. And so within reason, it could be something that we would do to help palliate those symptoms while we're awaiting the treatment to take effect. Probably skincare is another thing to consider, because that edema is uncomfortable and patients will feel achiness and they're prone to skin breakdown. So we want to make sure that they do not have that.
Are there any emergency management strategies? Is this something that could take a turn very quickly with patients?
Sadly, yes. Actually, because I am a critical care oncology nurse, I do see patients who present so late that they end up having to have mechanical ventilation. They end up having to have blood pressure support on a temporary basis. It's really a balancing act, though. When we give blood pressure support for the blood pressure on the left arm and the right arm's elevated, it's really kind of a challenge to figure out how to do that. But the idea of the mechanical ventilation is that we take away the work of breathing, we help them relax, we relax all the muscles in that area, and we control it so we can optimize that cardiac respiratory function by doing that. Probably the other emergent intervention that I want nurses to realize is that if you've decided there's a clot, you want to get that anticoagulation started as soon as possible, because what you don't want is a full occlusion, because that could lead ultimately to an intracranial event or a cardiac arrest. I mean, unusual, but I can think of one patient very specifically that we had to sit bolt upright because every time we put him down, he would have bradycardia and nearly arrest. And that was all because he was so compressed. He was not getting enough blood in the heart to put enough blood out the other side.
That's a great example. And I think those are important things to keep in mind. Unfortunately, these things can turn south very quickly. And that's why we're doing this and we're talking about these things, because it's so important for oncology nurses to understand these emergencies. And once a patient starts showing these signs, this is something you need to keep really close tabs on. So, what assessments should oncology nurses use to monitor a patient's severity, or is the treatment helping and are they improving?
I think that we always start with a total body assessment. And it's hard because this patient's going to present with potentially neurologic symptoms, cardiac and respiratory symptoms, as well as just generalized discomfort and constitutional symptoms. We're so focused sometimes on febrile neutropenia and the very classic complications that this one is a little more subtle. And so the nurse needs to be very comfortable with their cardiovascular assessment in general and be looking at vessels and be looking at jugular venous distension and pulsations. Those are not things that we emphasize in oncology orientations because they aren't something that we see in every patient. But their appreciation, I think, of that vascular pathology will help guide them in determining the classic cardiac assessment. The other is understanding that a low blood pressure may not always be evident because of the pressure in the vascular system, but it may be noticed through other things like diminished bowel sounds, diminished urine output, and more subtle ways of knowing that you're not adequately circulating. So those are some assessment skills I think that you can also add to that equation.
So we've got new oncology nurses that are listening. What considerations would be kind of the top care priorities for patients with superior vena cava syndrome?
Well, as a nurse, I would have to tell you comfort is number one. And the reason is that a patient who's more comfortable will naturally have less cardiopulmonary symptoms. And so I think that we as nurses need to advocate when the patient is uncomfortable. And it's not your classic pain in my hip kind of thing. This is a more subtle, I can't breathe. I have a sense of impending doom. I'm panicked. I want somebody beside me. So it may sometimes appear to be a psychosocial coping issue when it really is a physiologic one. So I think your priority is really to think about all of the things that we've talked about in fixing cardiac problems and fixing respiratory problems and fixing the headache and feeling of head fullness to make them more comfortable. I mean, I would say, yeah, ABCs, always our top priorities, but comfort is a big one for these patients. And reassurance that as the tumor shrinks, the symptoms will subside, but it may take a while.
That's such a good point. When these patients that we're working with, they're anxious because of the diagnosis that they have and the unknown of the treatments that they're experiencing. And now they're having these other feelings. So it's really important that we as nurses are able to really listen and ask the right questions when they are exhibiting these more psychosocial type things like you mentioned, because it really may be a physiologic feeling that they're having causing that. And if we're not asking the right questions, we may not get the right answers. So I think that's really a good point that you made there. Brenda, I want to thank you for the time that you've given us today and talking about this onc emergency. It's such an important topic for us and for our listeners to make sure that we understand and know how to assess with our patients and what kinds of things we as nurses can do. We're coming to the end of our time today, and I have a couple questions that I always ask at the end of our podcast, and I would like to ask those to you now. And the first one is, what are common misconceptions about superior vena cava syndrome?
Well, we often think of this as something that is a sign of terrible, bad, irreversible disease, when in fact it could be the presenting symptoms. So you do need to really look at the patient's trajectory of disease and determine if there is a viable clinical anti-neoplastic option. I don't think everybody realizes it can be very reversible when you have a good anti-neoplastic treatment available. At the same time, you have to be sensitive to the fact that it will often recur as the disease regrows at a later point. And so then you have this discomfort that is profound, and that's not how anybody at the end of their life would like to be feeling. So it is, I think, misconceiving to many that it can be very reversible in some circumstances and not in others. The other thing that I found really remarkable that I did not realize is that some symptoms never go away. Now, you'll get these engorged vessels on the chest wall if it goes on long enough. Well, I learned from a patient that came back totally disease free after 20 years that they never went away. Those enlarged vessels on their chest wall were permanently that way. And so when I first saw this patient with dyspnea, I thought that they had recurrent SVC syndrome. Well, in fact, they just had some bradycardia from damage to their conduction system from the radiotherapy. So I think that's a misperception because I clearly had it, and I've learned a little bit of a lesson from it.
What's something about this topic that's not often discussed, but you wish people knew more about?
Absolutely, the subtle early symptoms. Again, from my own experience, I have missed this in my diagnostic consideration. I can think of a patient in particular that had SVC syndrome that came in with febrile neutropenia, and he asked me to cut up his breakfast because his arm ached and he was numbness and tingling. And then I noticed the big fat antecubital and big veins on his hand. I still didn't get it. I cut up his breakfast, and then I just went and said, gee, this is weird. Well, someone luckily said this could be SVC, did the scan, found it, put the patient on heparin, and his symptoms resolved. And yeah, he did have febrile neutropenia, but the fever was from the clot. So I just think those subtle early symptoms could be so helpful for ambulatory nurses, inpatient nurses, just thinking outside the box a little bit about your patients and their risk factors.
Absolutely. Thank you. So, what are additional training or education that you think oncology nurses need to better assist them in understanding and treating superior vena cava syndrome?
Well, I think that the first thing, and maybe this is less so today because of all the cardiovascular side effects that we see in the newer drugs, but I think really good cardiac assessment is something we don't emphasize in oncology orientation. And for these patients, it's an important part of recognizing the syndrome and recognizing improvement of the syndrome. I also do think that helping people feel comfortable with dyspnea is something we don't emphasize perhaps as much as we could. You know, all the symptoms have different scales, but most of us don't look at a dyspnea scale. Most of us don't target our interventions for that. I'm very lucky. I have had now my second doctoral student that wants to look at dyspnea in the patient population they work with. And so we're looking really to start with nursing assessment. And people are comfortable to ask the questions. They're not comfortable to know what to do with it.
And what are some additional resources, whether that's for patients or providers who want to learn more about the topic?
Obviously, the Oncology Nursing Society. And there is a whole book on oncologic emergencies available through your website. You know, I think that the classic places that we might suggest people go to are the National Cancer Institute. Cancer.net is sponsored by ASCO, the American Society of Clinical Oncology, and then the American Cancer Society. NCCN is my go-to, but to be very honest, I'm not real sure that there is a specific piece on superior vena cava syndrome, but it certainly is mentioned in the high-risk cancers as a complication that could occur.
Well, thank you again, Brenda, for spending the time with us today and for sharing your knowledge and expertise on this area. Do you have any final comments for us?
Well, I'm really glad you asked that because I remember there was an intervention I forgot to mention, and that is stenting the superior vena cava or grafting it. So in patients with a long life expectancy that have chronic SVC syndrome, we can actually graft that vessel or we can stent it open. And I forgot to mention that in the interventions because it's not classic and it would require some real specialized care. But I do want people to know that's an option because who wants to have recurrent SVC and be cured of your cancer, right? So that would be something you may want to consider in the small number of your patients that live with recurrent compromised SVC.
Well, thank you for remembering that tip and letting us know. Again, thank you so much for joining us. This has been an excellent episode, and I think one that will be very valuable to our listeners and to new oncology nurses as they're starting their journey in this area.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.